Okay, so I'll be talking a little bit about cubital tunnel syndrome following Dr. Papirski's talk on carpal tunnel syndrome. As you are aware, cubital tunnel syndrome is the second most common compressive neuropathy in the upper extremity after carpal tunnel syndrome. Interestingly enough, until the 50s, it was thought to be due mostly to a inward pointing elbow or cubitus valgus, a stretch injury from an elbow injury that would cause cubital tunnel syndrome. It wasn't until the late 50s that the anatomy of the cubital tunnel became understood and described. And then people started looking at the pathophysiology of what actually led to the compression of the nerve, inflammation, scarring, and ultimately the development of cubital tunnel syndrome. From an anatomic standpoint, the ulnar nerve develops from the cervical roots, C8 and T1, comes off the medial cord of the brachial plexus. The ulnar nerve then comes behind the medial epicondyle in the elbow, enters the forearm, and finally goes down into the hand, passing through Guillen's canal, another area for potential compression. Patients typically have symptoms of a combination or one or the other of motor or sensory problems. Motor can be a weakness in the intrinsic muscles in the hand. Sensory problems can be decreased sensibility in the fifth and half of the ring finger or on the dorsal aspects of those fingers. And it really depends upon where the nerve is being compressed and the arrangement in the specific individual's nerve of what fibers are being compressed. So you can have motor, sensory, or a combination of the two. Interestingly enough, with our more active lifestyles these days, the incidence of ulnar nerve compression at the elbow is increasing, and is also a real, it's increasing, and patients often present with pain and numbness and tingling with these. Again, how does compression develop? All of these compressive neuropathies are injuries. They're not cut, but from pressure, we get decreased blood flow, causes inflammation. Inflammation leads to thickening of the tissues, scarring. Scarring causes contraction of the spaces that these structures pass through. Ultimately, pressure occurs and the nerves get damaged. As a byproduct of the scar tissue, the nerve cannot move through its normal pathway that it needs to. Nerves need to glide, okay? And if the nerve is being tethered and can't move, that causes a stretch injury or what's known as a traction injury, which can often be the major component of the problem. Again, on physical exam, patients will present with numbness and tingling. They have motor findings. Provocative tests that will work are a compression test at the elbow, similar to a Phelan sign that you would do for carpal tunnel syndrome. How do you work these things up? Ulnar nerve compression at the elbow is a clinical diagnosis, history and physical exam. X-rays should be taken to rule out any bone abnormalities. Electrodiagnostic tests are usually confirmatory. However, as with carpal tunnel syndrome, 10 to 15% of patients can have a normal nerve test but have clinical evidence of cubital tunnel syndrome. So that can't be taken lightly, and unfortunately, because of insurance regulations and litigation, most bodies like to see a positive nerve test, and this is where occasionally injections can be helpful in differentiating things. But again, for the ulnar nerve of the cubital tunnel, you have to be very careful. It's very easy to injure the nerve at this level. Non-operative treatment can consist of an elbow pad, changing the mechanics of what the person is doing, avoiding aggravating factors. If it potentially is a causal thing with a workers' compensation, sometimes it's not the activity the person is doing, it's the way they're doing it, okay? And sometimes ergonomic studies need to be done to actually have that person do that same job, but maybe not lifting high over the head in order to do that elbow motion, which is causing further aggravation. Typically, if ulnar nerve compression is going to get better, it usually does so within 2 to 3 months of instituting the non-operative treatment, elbow pad, anti-inflammatories, and changing some behavior. If not, those patients are then candidates for surgery. As with many of our upper extremity conditions, there's more than one operation. Initially, people were very aggressive, doing full submuscular transposition, where the entire muscles at the upper arm were divided, the nerve was placed underneath. Problem with that is it takes a long time to heal. You got to keep them immobilized. You get a lot of scarring. What happens? The nerve gets tethered, can't move. People get worse symptoms. So I think that more minimalistic approaches have become the norm these days, and a lot of it depends on where your training is. From simple decompression of releasing the structures that compress the nerve and leading it where it normally likes to be, behind the elbow, and sometimes adding an epicondylectomy or resecting a small portion of the bone as well. I think most people who do a submuscular transposition don't really do a submuscular transposition. It's really a subfascial transposition where you lengthen the fascia, take a little bit of muscle, place the nerve underneath, and you actually make a sling. And if you make it large enough, the nerve can glide properly. One of the important things with doing ulnar nerve surgery is there are various areas where the nerve can be compressed. As a surgeon, you need to make sure not only do you release all of those areas so the symptoms resolve, but if you're doing an anterior transposition, you need to ensure that you don't then create a new problem by operating on the old one. So you need to make sure that you've released the nerve for a large enough period of section of the nerve so that it can be placed in a nice straight line from the upper to the lower arm, so that you don't wind up with the patient coming back with secondary problems of pain, which is usually the most common problem if their symptoms don't resolve. And that's usually due to scar tissue nerve getting tethered by new areas of compression that were created by the original surgery. Interestingly enough, with ulnar nerve surgery, if patients are identified, diagnosed, and have surgery if they need it within a year, 88% of those patients will get what's considered a good to an excellent result. It goes down to 67% if it's beyond a year. So again, from a workers' compensation standpoint, you really need to have causality in all these things determined as quickly as possible whether the patient does or doesn't need surgery, so that you're not delaying things to create an even worse problem while two sides are arguing over who's responsible for paying the claim. Postoperatively, as I mentioned, originally, a lot of splinting, 3-4 weeks. Now, most people go to putting patients in a partial splint and getting them moving in 3 to 5 days after surgery. At least that's what I like to do, get them in occupational therapy. Again, the whole key here, get that nerve moving, get that nerve gliding so it doesn't get stuck in scar tissue, and you wind up with a persistent problem. As far as return to work, patients should be able to be returned to work within a couple of weeks after the surgery if the company will accommodate, and probably about 6 to 8 weeks after surgery to return to full duty, assuming no other problems.